I'm Linda Hagge, Senior Director of Development at School of Medicine Advancement, and I have the pleasure of working with this team, among others here at MedEd, doing really amazing work that you'll soon hear more about. So today, please, I think everyone's got the lunch. There is a bathroom. You turn left down there. You go down this hall, and on the left there are restrooms. What we're going to do is Dr. Fox is going to do an overview of the presentation. As you can see, we have a patient demonstration. Some of the medical students are going to speak about their experience using ultrasound and traveling overseas. And then at 1 o'clock, we'll leave this room, and anyone who could stay another extra 15, 20 minutes is welcome to come up one floor to the 4th floor with us. We are going to tour you through the new Ultrasound International Training Institute that we are developing on the 4th floor. So that's happening at 1 for those who are interested in staying for a very brief tour. So with that, I would like to introduce our leader of the Ultrasound Initiative, Dr. J. Christian Fox. And he is a professor of emergency medicine here at UC Irvine School of Medicine, assistant dean of student affairs, and director of our ultrasound program, the ultrasound training program. He has, I learned actually today, 3 textbooks that he's edited, 2 of them just by himself, 50 peer-reviewed publications. He was an undergraduate here at UC Irvine and then went to Tufts. We lost him to Tufts temporarily for medical school. But he came back for his residency and has been here on faculty since 2001. He won't tell you this, so I'll tell you, an international leader in portable bedside ultrasound technology. And with that, Dr. Fox.
Thank you, guys. That's nice. Thank you. It's wonderful to have my team here, and thank you guys so much for coming out and learning about what it is we're doing here with ultrasound. So, and thank you for that introduction, Linda. So we'll start with one of my favorite quotations ever, and that's by one of my medical students, Chanel Fischetti, who happens to be over here in the audience today, and says MS3, but really she's just practically an MS4 pretty soon here. So, but last year she came up with this thing called UltraFever, and UltraFever is the desire to infect others with a passion for ultrasound in order to spread ultrasound medical education and research virally. And that fever, I think a lot of us have caught that UltraFever here at UC Irvine, and it's been a lot of fun. So I'm going to tell you where we started. Before we caught the fever, this is kind of where we started. We started here with this wonderful quote by Dean Clayman, and if you think about it, it rings so true, which is really what we do at the bedside, taking care of our patients, whether we're in the emergency department, in the clinics, in the hospital, in the OR, really hasn't changed much since the time of Hippocrates. I mean, we go to the bedside, we look, we listen, we feel, but, we're limited by the physical examination. 1816, there was a new technology that came out, the stethoscope. But ever since the stethoscope, we've sort of been limited by that physical exam. So part of this, that's part of the setting, the background, if you will. And what about that physical examination? The physical examination, that time-honored approach of laying on of the hands was made famous, actually, one more time by Abraham Verghese. You may know who this person is. He's sort of a modern William Day Osler. He's probably the most famous physician of our time right now. And he goes through something called the Stanford 25. He wrote about the Stanford 25 and published it in the New York Times. And it's basically the 25 things that every Stanford med student has to know how to do before they graduate in terms of the physical examination. And well, this New York Times article went viral, and Dean Clayman got a hold of it and read it and said, Dr. Fox, I bet there's something we could do at UCI in response to the Stanford 25 with ultrasound. Something he called the Ultrasound 30. And the UCI 30, I should say, is the 30 things that a UC Irvine medical student can do with ultrasound. And that was published actually in a peer-reviewed journal called Academic Medicine. It was published 2 days ago, so this is hot off the electronic presses, so to speak. It's not in print yet, but it is published online. And this is the 30 things that every UCI medical student can do. In fact, it takes point by point what the Stanford 25 talks about in terms of doing a physical exam throughout the entire body, point by point, and matches ultrasound to it, and explains how ultrasound can go a lot further than the physical exam indeed can. And we think about, a lot of people come to me and say, I know ultrasound's for babies and looking at, obstetric stuff, but, really, what else can it do? And ultrasound is wonderful, and some people don't know this, but you can look at ultrasound throughout the entire body. You can start at the brain and look at the vasculature in the brain and come up with diagnoses there, strokes, and you can diagnose brain death, and you can look at the flow. And just in terms of anatomy and physiology, you can see the blood flow as it connects throughout the brain on ultrasound. You can look at the neck veins and also the arterial structures of the neck, looking for plaques or blockages in the cardiovascular system. And if you look at all these things, I'm not going to list them all here to you, but if you look at all these things here, this is all from the Stanford 25 with the extra 5 things we added for the UCI 30, and that basically encompasses what we're doing here with ultrasound. But what else is important is that what you should know as a background here is that CAT scans is the other way to look into the body. Other than using ultrasound, you can look into the body by cutting it open with a scalpel or looking with ionizing radiation. We know that with CAT scans, one CT scan of the abdomen pelvis is, depending on the settings, anywhere from 500 to 1,000 chest x-rays worth of radiation. And so a CT scan, something to think about there. My generation of physicians has really turned to CT scan as the principal way we image our patients. Unfortunately, it does incur quite a bit of radiation, and we know that radiation is ionizing and can lead to cancer. So we're going to be very careful with how we utilize CT scans, hopefully going forward, in light of all this ultrasound training. But this ultrasound training just couldn't happen anywhere. You need a place that's got the perfect setting. And I think a place like UCI is the perfect thing. So I'm going to play this little video here for you to give you a little background on what it is here we do at UC Irvine.
I think we're only really scratching the surface of where technology and healthcare are going over the next couple of years. There's always new things that come up that are worthwhile of investigating.
It impacts you in terms of research, patient safety. You're able to learn more. Clinicians have more information at their fingertips.
We have the environment here. It's this milieu of really open-minded, creative thinking people.
We're trying to create that next generation of physicians that are willing to make those kind of huge leaps in the way that they practice medicine to provide new ways of caring for patients.
UC Irvine is a world-class education. I really like the ultrasound program. Ultrasound's been around for a long time. What's really changing is how we're using it.
The medical students have had ultrasound integrated into their curriculum since day one. Now, we've got it condensed down to a single handheld unit with the same image quality and power.
I really wanted to do something abroad. I love traveling. We saw this massive kidney disease epidemic in Nicaragua, so we were able to bring down some ultrasounds there. I realized that in medicine, any little extra effort you put in, you could really see a major result and really impact people's lives and make them happy. It's probably the one thing that's gotten me most excited about my medical education.
I chose UC Irvine because it really seemed like it was more cutting edge.
It used to be the first 2 years of medical school was bookwork, and the second 2 years was clinical. And that transition between the two is a very difficult transition. With the Simulation Center, the students are getting exposure in the first 2 years to more of a clinical setting.
Everything is very real. You actually feel like you step into an OR. It provides this really state-of-the-art environment for us to learn.
When the iPad first came out, it really allowed for the first time for students to get all of their content really in one location. That gives them opportunity to be a little bit more nimble with how they can process information as it comes to them. And since then, every new class that's come in, we've given them iPads. Because of the flexibility in the technology, it's providing more opportunities for our students to get engaged.
UCI is really focused on technology.
People worry about technology being a tool that sort of separates physicians and patients. With technology, either at the bedside or in the room, they can now interact with their patients on a much more meaningful level.
As a physician, I think we will be able to be more prepared, and ultimately it provides benefit back to the community as a whole because we are the ones who are serving them.
It's absolutely essential going forward if you are going to be an effective physician, that you are able to utilize technology not only to get information about your patient, but also to get information about what the latest research is.
We've reached a time here at UCI where the conditions are right. It's the people that are in medical school now that grew up with technology. They grew up with the internet in their pocket. And I just love that we're giving our students that opportunity more than any other medical school in the world right now. So this setting here that we have in the background that you've had so far, I think tees you up to wonder about who the key players are now in terms of how do we get ultrasound integrated. I think a major key player is the healthcare market, the healthcare industry itself. And as you know, there's a big cost reduction coming down the pike right now. We're going to reduce healthcare in this country by 25% by the year 2018. And that's going to happen on small ways and scale and integration and some operational improvements. But the biggest way that we're going to be able to reduce the cost of healthcare is by changing the way we do things clinically re-engineering. And by eliminating waste and unnecessary testing and having poor outcomes and this shotgun approach to practicing medicine where we just CT everything that walks in the door. Many times those are unnecessary tests. They can lead to other problems like hospital-acquired conditions. I think ultrasound really is going to be a key player here in making physicians better on that first pass metabolism, so to speak. When they see the patient armed with this bedside portable imaging modality at the bedside, using that themselves to, as the patient's talking to them, to integrate that into the care of their own patients, I think it makes you more of an accurate doctor, and it makes you order less tests. And the Institute for Healthcare Improvement, what they call the triple aim, this is like every doctor is hearing about this in the country right now, the triple aim, very popular. And it's three things. It's experience of care, health of the population, and then cost. And ultrasound, I think, really is on all three of these prongs. And I gave this talk to 200 chief medical officers, not this specific talk, but I addressed this issue to 200 chief medical officers 2 weeks ago at a big forum in Florida, and they all wanted to know about how the triple aim and ultrasound are going to converge. And I can tell you that in terms of the patient's perception of their care, their experience of their care, when the clinician themselves performs the ultrasound at the bedside, as I'm doing an ultrasound on my patients, I can show them on the screen their organs and, frankly, their pathology. And I think that helps a better communication between myself and the patient. And if I have a patient who's, for instance, somewhat non-compliant with dietary or medication regimens, I can show them their heart and why it's not squeezing very well. I can show them the extra fluid in their lungs and try to get them around to this is why you can't eat salty food, or this is why you need to be on your antihypertensives. I can show them the plaques in their arteries. Somebody is concerned about a sudden loss of vision. I can show them their retina or their optic nerve sheath. I mean, I can really explain to them their diagnoses at the bedside. And I think that's probably the most important reason to use ultrasound in the end, is the patient experience and bringing the doctor and the patient closer together. People hear technology and they immediately think, oh, technology gets in the way of the doctor-patient relationship. Or they hear ultrasound and they go, well, what about the physical exam, the laying on of the hands of the doctor and onto the patient as a way to connect those two. And I think laying on of the ultrasound probe onto the patient and visualization of the organs and their pathologies on the screen, or lack of pathology on the screen, really does connect myself to the patient. In fact, as an emergency physician, when I take care of my patients in the emergency department, I see 30, 40 patients a shift. And over the years, patients have come back to the emergency department and recognized me as the doctor who took care of them. And I don't remember them because, I'm an ER doctor and I'm not a primary care doctor, but they remember me as the doctor who did the ultrasound. I get that a lot from them. So I know that the patients are responding well to this ultrasound. And then when you put this in the hands of every clinician at the bedside, whether they're a neurologist looking at stroke and other things in the brain, or whether they're an orthopedic surgeon deciding whether or not to operate on a shoulder, or in the ICU, or in primary care, I think that overall is going to improve the health of the population once it's in everybody's hands. and we're cutting costs and being more accurate at the bedside. And finally, cutting costs, the per capita cost, I think, not shotgunning so much and finding, looking for a needle in a haystack and finding, being more accurate with ultrasound and crossing things off your list. I think as healthcare switches from a fee-for-service to more of a capitated approach, these physicians, our medical students, will emerge as the winners in that new model. Another key player here are the companies that make the ultrasound machines, and Sonosite has been a very generous donor to our medical school and is providing us, they just happen to be the world's leader. They have the market share, I should say, of the portable market, the handheld market, and so we work closely with them to help develop their next product line. And then UniHealth Foundation, 3 years ago, gave us a very generous donation that is running out next month, but we're right in their vision of innovative activities that positively impact healthcare, so it made sense to partner up with the UniHealth Foundation. And none of what I'm about to tell you would have been possible without the UniHealth Foundation. And none of what I'm about to tell you would be possible without the energy and the enthusiasm and the infectious fever that has occurred in my medical students as a result of this ultrasound. And the person that you see here, this is Kaya. She founded the ultrasound interest group. She's now one of my residents in emergency medicine. And this is Chanel, and you can see Brad is here, and Tatiana. And these students have really sort of energized everybody around them by being both disruptive and supportive of how this process has gone out. And I'll explain the disruptive part in a minute. But the ultrasound interest group, obviously a key player here. I took that photo of them at a conference where they were presenting their research on ultrasound. So what the heck have we done with ultrasound? Well, we've done a lot of research, and we've done a lot of this research. We have presented this research. We have disseminated what we've been able to learn here with our ultrasound curriculum and to the world. We've gone out to the American Institute of Ultrasound and Medicine. This is the world's largest ultrasound institution, to the Association of American Medical Colleges, and to their national and their regional meetings. We've been working in lockstep with that organization. And as I mentioned, the Academy is an organization of chief medical officers, OBGYN societies, emergency medicine societies, societies of ultrasound, even an ultrasound, sort of a Comic-Con type of thing at Castle Fest. We've done a lot of dissemination of our knowledge here. And these are my medical students here presenting their research at various conferences, and they present their research not to other medical students, so to speak, but to deans. And so they're in an audience, and there's maybe 30, 40 deans. They're at the podium, and there's 30 or 40 deans in the audience, and you know, to hear the dean of a very highly regarded medical school start firing questions here at Brad Jacobson in the middle of his talk, and the passion that he has to communicate our curriculum to him was just awesome to be able to watch. And so I'm very proud of them doing that. And these weren't just, a lot of times people say abstract presentations are empty promises. And these have resulted in publications in great journals like Global Heart and Medical Education and Academic Medicine on the topics of medical students diagnosing the differential diagnosis of cardiovascular symptoms, how our curriculum is in the flipped classroom format, and also how we use it at the bedside to find lesions. And I would like to focus a little bit on research here for a minute. You know, we have currently 28 ongoing IRB protocols that are enrolling various subjects and studies right now, so it's a whole research machine. But one study in particular I want you to know about is my medical students have done, which is the Hypertrophic Cardiomyopathy screening study. So hypertrophic cardiomyopathy is the sudden athlete death in young athletes where the septum of their heart is too thick, and it occurs in about 1 in every 500 people. And so when they're exercising, you hear about it all the time. Somebody's exercising, and suddenly they're dead. They fall to the ground and they collapse. And there's this condition. The only way to pick it up is with an echocardiogram. EKGs don't pick it up reliably, so you need to screen for it in that way, which up until now has been a logistically very difficult thing. But in Orange County, we've screened in 2 years 2,526 students for it and found 5 students with this condition. Now, I haven't done these ultrasounds. My medical students have done all of these ultrasounds, gathered. They go into a high school and they screen 200 to 300 students in 2 hours with their 12 to 15 ultrasound machines. And it's a pretty remarkable logistical process, and all these images get read by pediatric cardiologists. And so look for that publication coming out soon. But suffice it to say, we'd like to say, or Dean Clayman is quoted as saying, Orange County is trying to be the safest county to practice high school sports in. But if you take this model and you replicate it throughout the country, then you could see how this condition can be picked up nationally as well. The other thing that happens is a lot of peer-to-peer teaching. So we have, initially it's difficult, when I first started the curriculum, I was doing all the teaching, my fellows were doing all the teaching, but as medical students started to learn themselves, they then become the teachers, and not just the teachers to each other, but to the teachers in the generations above them. And so you can imagine how disruptive that is. But one main way we've been able to teach introduce ultrasound and teach it to people from other medical schools is with UltraFest. I'm going to have Chanel come up and sort of on the fly here and tell us about Ultra. I have a video here, but I'd rather have Chanel just tell us. You can come to the mic and tell us about what UltraFest is.
Hi, thank you so much for coming. We really appreciate your time. UltraFest is basically this day where we have a free day, so medical students from all over can come. We have about 250 medical students from all over, mainly from California, but we've had students from Minnesota come, from the South come, and they basically get to rotate through these workshops. And we have 14 to 15 workshops, anything from anesthesiology, line placement, pediatrics, OB-GYN, and so we'll allow students to choose 6 of them. And they rotate through, and they're able to get hands-on stick time, which is basically time with the probe and time with the patient. And for many of these students, it's their first experience and exposure to ultrasound, and it's so powerful and impactful that they go back to their universities and say, hey, how come we're not doing what they're doing at UCI? So we've actually helped start similar programs at places like UCLA and UC San Diego, but it's only been possible through these days like UltraFest, where students actually get exposed to that. And we have our medical students teaching throughout that day. We have our residents and our fellows and our attendings. And it's just so powerful to actually see that and touch it and interact with your patients. So that's UltraFest.
Perfect. So hold on one second. So thank you about that. And the other way we do a lot of teaching is we go to other countries and do a lot of teaching as well. So, and I've got Brad, if you want to come up here. And so we've been to lots of different places, and I would just want them to both share their experiences with you. I'll have Chanel talk about Panama first, and Brad, you'll talk about Tanzania.
So in Panama, there's a group called Floating Doctors, and they basically work on the east coast of Panama in a region called Bocas del Toro. And they float into these different islands and basically provide medical care to these tribal villages, the Nobe people, who otherwise would not have access to care. And so when I went down with a few of our fellow classmates, we were able to take these portable ultrasounds into these clinics. And for example, there was a woman there who had traveled 2 days by boat to get to a hospital only to be turned away at 8 months pregnant because she wasn't able to receive her ultrasound. So we were able to take that ultrasound into her hut and provide her with one of her first prenatal ultrasounds, which was just really powerful and important because it helps with the positioning of the baby to let her know whether or not she needs to go to the hospital earlier rather than later. And so it was just so powerful, and we were able to teach a lot of the physicians and other students working through this project about what ultrasound can do in the rural setting.
And same type of thing in Tanzania. A group of first-year medical school students went down to a town called Mwanza, which is in the western part of Tanzania, right on the shores of Lake Victoria. And it was amazing after 1 year of medical school training how we were able to screen patients. I always tell this one story that we were at a clinic in Mwanza, and a lady came in that was 8 months pregnant, and it was myself and 2 other first-year medical school students in between first and second year. And we did this M mode on the ultrasound, which allows you to detect the fetal heart rate. And we were able to tell that woman right then and there, like, your baby's heart rate is dangerously low at this tiny clinic, and we're able to refer her to the general hospital in Mwanza. So just as a first-year medical school student, it was amazing to be a part of that process. And this program in Tanzania is getting really big now. We're teaching over 150 clinical officer students over there. And None of this would have been possible without the ultrasound machines that we get from UC Irvine, and then also the other companies that Dr. Fox has been talking about. It's been a really incredible experience.
Thanks, guys.
Thank you.
Your enthusiasm is infectious. We're starting to all get the fever now in this room, I think. I know I am. So we've been to a lot of places. This model has been replicated in various parts of the world, including in a very rural medical school in Australia, where we now have a really close agreement with, and then we were in Transylvania and a lot of places. But to see your medical students, for example, here at a conference, a millennial medical student like Chanel teaching a Generation X and then maybe a baby boomer over here how to do ultrasound at the American College of Emergency Physicians, and Samantha Cosentini, who happens to be here right now, teaching the previous generation how to perform ultrasound on the heart using a simulation device is somewhat disrupting, to say the least. And we've done a lot of great outreach as well. We have a lot of high schools come here to get exposed to what it's like being a medical student, but then to be able, for those high school students, and some of these are sort of at-risk high school students, for them to take the probe in their hand and put it on a model, on a real live person or on each other, and see the organs come to life, and the Doppler and the connectivity and all the organs has been really, I think, a way for them to really think about potentially a career in medicine there. So the question is, where are we going next? And we've done a lot, but we still got a ways to go. I think one of the challenges I have is ramping up the third and fourth year medical student experience. In when they get up to the wards and the clinics, I have machines up there, and I make weekly rounds, my fellows round with them, and offer that support. They record their images, we review those images, but I could definitely use more resources here to kind of bolster their education. This summer, we're sending over 50 medical students abroad to Brazil, Panama, Tanzania, Turkey, Vietnam, India, and Australia. So we're going to the world to teach our skills. But there's this sort of continuum, if you will, between undergraduate medical education, i.e. medical school, graduate medical education, residency training, and continuing medical education, and those are physicians who are already finished with their training. So I'm going to touch on that for a minute, because I think this is one of my main challenges here. To teach the residents, and initially I got some resistance from the various departments a few years ago, but now I'm having the opposite problem. I'm getting a lot of resident interest. A lot of their residency directors, their education directors are coming to me and saying, hey, we want this ultrasound education. How do we get it? And so they get my podcast. All of my content, by the way, is all up on iTunes U. It's up on the iTunes. It's free. Everybody can get to it. I've got over 50 podcasts up there. So the students get that, and now the residents find that, and they that's how they get the content, the didactic. And then they come to do ultrasound on a hands-on and a healthy volunteer. They get some stick time. And then they practice ultrasound on a task trainer. And then we have pathology-based simulators, which I'll show you in a minute. And then they go back to the wards and clinics and they practice ultrasound on their own patients. And then after about 25 scans per application, in other words, 25 gallbladders, 25 hearts, 25 kidneys, 25 whatevers, then they're competent in that area. Most of them are. There's some other testing we do, but in general, that's the pathway for the residents. And so when the residents start to get better at ultrasound, they then become more supportive of the medical students. But there is this kind of disruptive phase where certainly everybody in the room knows that the third-year medical student can outperform the resident and certainly the attending at the bedside with ultrasound currently in the current state of the system. And initially it was really sort of very disruptive, and now people just want the education. And then for the physicians out there who never got the training, and I've spent a lot of time prior to coming to medical student ultrasound, I was teaching mostly people out of medical school and out of residency, and they don't like to start with the podcasts. That's disturbing to them. They want me to feed it to them, hand it to them on a plate. And so they come to an ultrasound course, and myself and other experts lecture to them, and then we break up into do hands-on, we go back to lecture, hands-on, lecture, hands-on, and then they go back to their institutions and they do 25 scans per application. They get credentialed by their hospital, and then they find my podcasts at that point. It's kind of backwards for the practicing physician. That's okay. Now, in our hospital at UC Irvine, we have 12 different departments who do have credentialing pathways now, and so these physicians in our own hospital have a way to get credentialed. Now they just need the training, and so that's where I need. That's kind of where I'm going next with everything. And the way I'm going to do that is upstairs. Right one floor above you is an empty part of the building, and I'm going to, thanks to Sonosite, generous donation, I'm going to build out 3,500 square feet of it into this point-of-care training institute. It's currently under design, where you go from lecture to hands-on and back and forth, and there'll be a whole thing of simulation in here as well, all the latest simulators. But this is going to be a global, international presence. We're going to have half-day training for nurses to put in ultrasound-guided IV sticks on difficult patients, all the way up to 2-week ultrasound directorship boot camps. And I think it's really going to be focused on a best practice type of model, looking at all the national standards to do different procedures and ultrasounds. So that's ultrasound. You know, it actively burns in the knowledge of anatomy, of physiology, and importantly, of pathology, and it empowers medical students. It makes them feel like they have special skills, special powers to go beyond the skin and look into the body and share that with their patients and connect to their patient that way. And as an example of that, I'd like to have Joelle come up now and actually perform an ultrasound here. We brought a standardized patient. This is just an example of sort of how we do it and in real life. And while she's performing the ultrasound on a normal patient's kidney, I wanted to show you guys how some of our simulation technology works. And so what you're looking at here, the probe is in my hand. Can you guys see the probe in my hand here? And look how as I rotate this transducer in the air, it brings up the organs on the screen. And I don't know, can you guys see the ultrasound is the top image. There's a CAT scan from the same patient that corresponds on the bottom image, so they can learn their imaging anatomy and imaging modalities here, both CT and ultrasound. And I'll just point out these organs to you. This is the kidney here. Okay, here it's seen on ultrasound. This is the liver, the kidney, and on CT here's the liver, here's the kidney. And you can see that this kidney's got some fluid here in the collecting system. This is a patient who's got hydronephrosis from a distal obstructing kidney stone. And Dean Clayman loves this example, by the way. But you can see here, this is the dilated kidney with the black part here being all fluid, and that's what hydronephrosis looks like. So I was able to find it actually using a simulation device. Now, student Dr. Joelle Schlang is here, and she's performing an ultrasound. And yeah, I don't know if you guys can see it in the back there, but she pulled up the liver and the kidney on this gentleman here as I was performing it with the simulator. Okay, so we're going to go to the next window now, which is a subcostal view of the heart. And as she's going to go find that subcostal view of the heart, I'm going to pull up a case here of the heart as well. And case 1, I think this is the good one here. Okay, 32-year-old person comes in. Okay, great. And we're going to do the subcostal approach. Okay. And now as she's trying to find that heart, I'm trying to find the heart as well here. And let's see here, looking through. And okay, yeah, I'm getting there. This is a little tricky here. Okay, now I'm starting to see the heart. And the nice thing about the simulator is I could take off some layers here and actually see the heart underneath the rib cage as I'm going through it. And this is the idea. I don't know if you can you see it okay over there on your screen there, Joelle? Good. So I'm seeing the pathology. This patient up here actually has a large pericardial effusion. Our standardized patient, interestingly enough, does have a trace pericardial effusion, which can be physiologic, especially after an upper respiratory infection. So, but this one up here, this is more like what we call pericardial tamponade. It's blocking the flow of the heart, which is why this heart's not really beating too well here on this simulated on the simulator. Okay, so the next view we're going to show you is an aorta, and as she goes to the abdominal aorta, I'm going to find the abdominal aorta case I'd like to use up here. Let's see here. I'm going to go to. I think it's under, it's under vascular, and then it's under core aorta, and case number 6. All right, point A. Now as I do this, she's doing that. And what do you guys see on her screen? Can you see her screen there? She's showing you a normal caliber aorta, and let's see here. I am running into problems. Maybe I pulled up the wrong case here. I had a really cool case of a abdominal aortic aneurysm here. Oh, case 6. Sorry, I'm on the wrong case here. 1 second. Core aorta, case 6.8. And this is what an abdominal aortic aneurysm looks like. And I think you know what that is. That's Rodney Dangerfield actually had one of those, and my uncle did. And this is a very large vascular catastrophe. When that thing ruptures, there's a 50 to 85% immediate mortality rate. And patients come in with back pain, and it's been described in the past by William Osler as the great mimicker. And so student Dr. Slane can pick up the aorta here in a matter of seconds, and we can see what the pathology looks like with our nice simulation technology. And we're going to do one more ultrasound of the eye is next, and she's going to change the transducer. I'm going to pull up the ocular ultrasound, case number 7, and show you what an ocular ultrasound looks like in the setting of some pathology. So you can look at the eye using ophthalmoscope, and it's you get the eye to dilate, and so that you can see the back of the eye, and you can make out some structures there. And that's part of the physical exam, something we still teach here at the medical school. But we extend that physical exam past the eyelid by putting gel on the outside of the eyelid. And on the ultrasound screen up here, what we see is the signs of a retinal detachment. This membrane right here is coming off the back. This is the back of the eye back here. And as you fan through it, this shows you how ultrasound is important to fan all the way through a structure. We see the detachment. And Joelle is showing you what a normal eye looks like over there on this gentleman without a retinal detachment. And you can see all kinds of great anatomy here in the eye. And so that pretty much concludes our scanning portion. I do want to have one more person come up, and that's Dr. Rishenkopf, and then we'll open up to questions. But Dr. Rishenkopf is going to tell us his perspective being an internist, and he is an internist in Canada from the University of British Columbia. His university sent him to me for a year to train him in ultrasound, and he's going to tell us why they did that and what's been important and what he's learned while he's been here from an internist's perspective and from a Canadian's perspective, which is very different, let me tell you.
Thank you. So I think we've all been able to see the impact that ultrasound has had on medicine, especially from an emergency medicine department sort of perspective. And because of pioneers like Dr. Fox here, we're now starting to see the evidence sort of turn out. We know that this affects patient outcomes. We know that this affects patient satisfaction. We know that this affects sort of costs, length of stay, all these types of things. And we now have the literature to show that. So no longer can sort of the non-emergency medicine docs ignore point-of-care ultrasound. And that's really starting to play out in different people, or sort of in different faculties. And so, unfortunately, in internal medicine, we seem to adopt a lot of these technologies a little bit later than other faculties do. But even in internal medicine now, we sort of can no longer ignore this. Unfortunately, we're still at the stage right now where we really lack the expertise to run these programs. So you really need somebody to come in who has the training then to pass that along to the residents and students and so forth. So that was sort of the objective from the program in Vancouver, was to send me out to Irvine here to gain a little bit of that expertise in order to bring that back to Vancouver and then help develop an ultrasound training program within the internal medicine program at UBC. And I've certainly benefited from the significant amount of expertise that's out here. UC Irvine and Dr. Fox are very well known within sort of the international community as a place where you can gain that expertise. In fact, the program director at UBC spent a couple of years scouring North America basically to try to find places where gaining that expertise would be best. And after searching and talking to a lot of different people, a lot of different programs throughout the US and Canada, said this is the place to come. And so we were able to negotiate with Dr. Fox here to allow me to come out for a year, focus on point-of-care ultrasound, learning the skills, number one, just to be able to actually practice the ultrasound component of things, but then also to gain some of the skills and knowledge around developing a program. And hopefully then I'll be able to take that information back to Vancouver and disseminate it and build that expertise within the program in Vancouver. And it certainly, you know, a lot of the applications that we see in emergency medicine carry on over into the internal medicine aspect of things. We're often taking care of acutely ill patients that were being referred from the emergency department, or if we're up on the floor, you have people that may have had a turn for the worse, and we need access to these types of imaging or diagnostic modalities that are going to help us make real-time decisions quickly, and allows us to have then the autonomy to make those decisions and make the diagnosis and those treatment decisions in real time. And I'm 100% sold on the ability of the ultrasound to change my practice and change the practice of a number of other people sort of within residency programs in the medical schools coming up. So I've been very fortunate to benefit from the expertise here, as well as the resources here. And I'm confident that as I go back to Vancouver now, that I'll be able to really make a big contribution there.
Thank you. Thank you, Shane. I have learned more from Shane in this last year than I fear that I have taught him. He's taught me more, actually. And he's been amazing and taught a lot of my students, almost all the students, actually, as well. So thank you, Shane, for being here this year. So that's the sort of the program in a nutshell. And I think I'd like to open it up right now. I think we have some time for some questions for either me or anybody else here. And whatever you guys want to talk about, what's on your mind?